All right, so my name is Jamie. I'm a PhD at the Global Disability Innovation Hub. Kathy gave me the privilege of sort of titling my role here, and I like to say that I'm a population health data scientist, so I'm going to be talking about the innovative ways that we can use AT data. So as we've already kind of heard, the AT data conversation is really consistently geared towards the collection of new data as a critical need globally, and this is absolutely the case. In trying to keep up with new surveys and data sets, we at GDI have mapped 207 publications, 62 national surveys, 47 population-based cohort studies that all collect data on AT access indicators. And we also know that 27 countries have now integrated AT questions into their routine national data collection. However, if you search through all of these resources in our data portal, you'll find that it's really only a handful of countries and very few types of assistive products that are routinely represented in this space. And often, datasets that do exist are underutilized or have never actually been utilized at all to study AT access. So a wealth of data does exist in the AT sector, and we will always need more, but we can learn so much more from the data that we do have. The novel ways we can use AT data are innovations by themselves, and one of the first tasks is getting the discordant data to actually work together. For example, often different population-based surveys are conducted in a country over several years, which are similar but not directly comparable. But these surveys can be harmonized, which is a valuable process to observe trends over time. And if the key outcome measures can be adjusted to align within reason and the sample populations can be trimmed to have the same representative demographics, then the findings from each survey can be directly compared and trends can be observed. And when we look at multiple data sets at once, we can also identify anomalies in these individual data sets that can be identified and explored in ways that a single data holder is not able to explain themselves. And this lets us understand the effects of different study designs, like how a specific method of data collection might over or underestimate specific results. Hello, hello, hello. Okay. All right. Thank you, Tiggy. that was fabulous. Thank you all for waiting. Okay. So my last sentence was just to say that we're only able to look at anomalies in these data sets if we have the benefit of being able to directly compare multiple data points, because you can't observe a trend with only one data point. And these trends are extremely valuable, and I often think my coworkers get sick of me listening to me talk about trends, because that's all I talk about, but obviously not, because here I am. But they're very important because we typically live in populations that are dynamic because their demographics are changing. And global aging is a huge driver of this. We have more people surviving to older ages in every country, and this aging process looks different in different places. It might be happening at different speeds or be at different stages, but it is happening everywhere. And many countries are already working to meet the needs for older adults in their populations, who now comprise a proportion that is unprecedented in the country's history. On the other hand, other countries that are starting to age have opportunities to prepare for these needs in advance. But we cannot meet these needs in any case if we can't keep up with them. So we have to understand how these needs have changed already so we can forecast how they will change in the future. And with multiple waves of data, we can conduct retrospective analyses to identify the social and health factors that increase the risk of an individual having an unmet need for AT. We can see how that level of risk varies across demographics within a population and connect this with the increasing or decreasing numbers of individuals in each demographic to scale the need. In other words, if the current trends continue, we can estimate how an existing disparity will grow if nothing is done to address it. By this process, we're identifying clusters of disproportionate need, and with this understanding, we can engage much more closely with specific communities to find out where the provision process isn't working. So we can use this method first to orient our lens, so to speak, and then to zoom in. Of course, we love testing what works at GDI. Forecasting also provides us a way to look at the impact of interventions, new assistive products, and new policies by examining the key access indicators before and after implementation. And this is universally needed with global aging, but it's also needed to address sudden shifts in need for assistive technology, like what happens in conflict and humanitarian settings. And continuing to collect data allows us to validate these forecasting models and even understand if they apply in other settings that lack past waves of data or where it's not feasible to collect data so routinely. So over all of these stages, though, when you work with existing data, you have to account for gaps that you can't fill. So when looking at population level estimates, you have to assess how representative are these data really of this population. So disability is often incompletely or completely misrepresented in public health data sets, even those targeted towards capturing it in a comprehensive way. For example, if we rely only on health record data to learn about AT need, then we will miss individuals who don't reliably engage with the healthcare institutions. Population cohorts that are used to study healthy aging often do not enroll people who are institutionalized or have pre-existing support needs. Disability registries are likely to underestimate the prevalence of more mild limitations or disabilities and of course require someone to be willing to register as disabled to be included. Or if AT is only studied where it interacts with education or employment, we will not capture the needs of individuals who are retired, for example. We will also not capture the benefits of AT outside those two domains. Government strategies and policies are absolutely informed by these data, and innovations are scaled based on these estimates, and if we pile on more and more research that does not account for who is missing, these representation gaps will be exacerbated, and we will be pushing disabled people further into the margins. But that being said, there are innovative ways to make progress with these data. You can use mixed methods approaches, which benefit from having complementary data sets. And this can look like including qualitative data collection like storytelling and interviews among a smaller sample, and using that to inform what lifestyle variables are tested in a model working with larger scale quantitative data. In assessing the representativeness of a data set, describing the group of people not included in both the data and the resultant model is also important, like those who never experience a certain outcome or those with missing data. And this is particularly relevant for intersectionalities, as it is often the individuals who are more vulnerable with the most complex needs who are not within the remit of data collection or may aim to avoid it altogether. And finally, there's a lot of work just to be done reviewing and describing gaps in the existing data so that we can inform and encourage better data collection on AT access. We need to reflect critically and continuously on our approaches, because how we design data collection and analyses need to complement the changing conceptual understanding of disability, inclusion, and assistive technology.